Can't wait to watch the game tonight.
Welcome back, folks. We are back into the game.
And Atwood smashes the ball in its sky's center field. There goes Kremer lunging forward to catch the ball, and he's missed it, folks. Looks like Kremer has hurt himself. He's hurt himself real bad going for that one. This does not look good for Kremer, and we see Kremer there holding his wrist like he's there in a lot of pain.
Fantastic effort by Kremer, but that's not good news. Let's see that again in slow motion.
By the looks of it, Kremeyer has injured his wrist area by landing right on top of his bended left hand. You can see his agony as the glove bends inward as his outstretched arm hits the field. Without a doubt, folks, this looks like a serious injury for Kremeyer. He could be looking at a broken bone or some kind of sprain in his wrist and definitely time off the field. You can see it again, folks, as Kremeyer dives for the ball, his palm side of his hand and his abnormally bent fingers and wrist almost takes all the force. You can see him immediately grabbing his wrist in pain.
Luckily, there's a doctor at hand, no pun intended. We'll be back after the short break and talk to Dr. S. Skeleton, who's assisting Kremer's situation at this moment and who'll give us an expert insight into Kremer's injuries. Joining us now is Dr. S. Skeleton, and she is here to tell us a little more about the injury.
Hello everyone, my name is Dr. S. Skeleton. Me and my team have examined Kremer today, and I will be going through the anatomy of his injury and the anatomy of the hand and the wrist. As Kremer reaches out to catch the ball with his left hand, his left wrist exhibits supination and extension. As the ball comes into contact with Kremer's glove, his supinated wrist hyperextends. Kremer lands on the palmar aspect of his hand, his wrist remaining in a supinated position but exhibiting further hyperextension. Kremer's hand slides forward against the ground before bouncing off the ground, his wrist returning to an extended position. Kremer's left hand and wrist have been placed under severe stress, and there may be an injury to the bones and ligaments as well as their surrounding structures. In this segment, I will be explaining the anatomy and histology of the hand and the wrist, providing a better understanding of Kremer's injury.
There are 8 carpal bones in the wrist. They are organized into 2 rows and connect the forearm to the hand. The proximal row from the lateral to the medial are the scaphoid, lunate, triquetrum, and pisiform. The distal row from the lateral to the medial are trapezium, trapezoid, capitate, and hamate. The carpal bones form 3 primary articulations: the radiocarpal joint between the forearm and the wrist, the midcarpal joints between the proximal and distal rows of the carpal bones, and the carpal metacarpal joints between the distal row of the carpal bones and the hand. The ligaments of the wrist provide support and stability and can be divided into extrinsic and intrinsic ligaments. Extrinsic ligaments connect the carpal bones to the radius, ulna, and metacarpals. They include the radial collateral ligament of the wrist, the palmar radiocarpal ligament, the palmar ulnocarpal ligament, and the palmar radioulnar ligament. The intrinsic ligaments connect the carpal bones to each other and include the intercarpal ligaments. With Kremer's injury, the radiocarpal joint is of most interest. It is formed between the distal radius and the proximal carpal row, including the bones, the scaphoid, lunate, and triquetrum. It is classified as a synovial condyle type joint. The radiocarpal joint allows for 70 to 90 degrees of flexion, 65 to 85 degrees of extension, can abduct 15 to 25 degrees, and adduct 25 to 40 degrees. From the footage, it looks as though Kremer's wrist has been extended more than 85 degrees.
In this segment, I will be talking about the range and capacity of movement and movement axes of the hand relating to Kremer's injury. The hand consists of an intrinsic muscle. This muscle can be divided into 5 groups: thenar eminence, hypothenar eminence, dorsal introsei, palmar introosseous, and lumbricals. There are 4 muscles that make up the thenar eminence: the abductor pollis brevis, the opponens pollis, the flexor pollis brevis, and the adductor pollis. The abductor pollis brevis helps to abduct the thumb, and the adductor pollis brevis helps to adduct the thumb. Both the abduction and adduction of the hand occur in the frontal plane at the anterior-posterior axis. Flexor pollis brevis allows flexion of the thumb at the sagittal plane.
The opponent's pollice allows thumb opposition which takes place at the transverse plane and the longitudinal axis. The hypothenar eminence consists of three muscles: the flexor digiti minimi brevis, the abductor digiti minimi, and the opponens digiti minimi. The flexor digiti minimi brevis, highlighted here, flexes the metacarpal joint of the little finger. The abductor digiti minimi allows abduction movement and flexion of the little finger. And the opponens digiti minimi rotates the metacarpal of the little finger towards the palm, producing opposition. At the dorsal side of the hand, the dorsal intrasi muscle of the hand is involved in flexion at the metacarpophalangeal joints, extension at the proximal and distal interphalangeal joints, as well as abduction. The palmar introsi muscle, on the other hand, is involved in flexion at the metacarpophalangeal joints, extension at the distal and proximal interphalangeal joints, and adduction of the fingers. The last intrinsic muscle, which is the lumbricals, helps to perform flexion at the second to fifth metacarpal of the finger and extension at the proximal and distal interphalanges.
In this crema injury, fracture at the metacarpal shaft reduces the ability to perform flexion and extension on the fingers, either due to the presence of a bony deformity, digit shortening, loss of knuckle contour, or soft tissue injury. Furthermore, shortening of the metacarpal bone could reduce the efficiency of intrinsic muscle to contract, thus producing extension lag that is associated with significant power loss. Presence of limitation in metacarpophalangeal motion can lead to stiffness in joints. In this segment, I will be talking about the vasculature of the hand and the wrist relating to Cremai's injury. Ulnar nerve supplies the intrinsic muscles of the hand and innervates the medial 1½ fingers, that is the half of the ring finger and the little finger, on both palmar and dorsal side of the hand. The median nerve supplies the forearm flexors and pronators and the thumb muscles and innervates the rest of the volar aspect of the palm and fingers, that is the 2½ digits and the thumb. On the dorsal side, it innervates over the tips of the fingers to the base of the fingernails of the 2½ digits and over the tip of the finger to the interphalangeal joint of the thumb. The radial nerve supplies the extensor muscles of the arm, the metacarpal phalangeal joints, the extensor digitorum communis, the interphalangeal joint of the thumb, the extensor pollicis brevis, and the metacarpal phalangeal joint of the index finger, that is the extensor indicis, and innervates the rest of the dorsum hand, that is the lateral 3½ fingers. The C6 nerve innervates the lateral forearm, the lateral hand, thumb, and the index finger. Middle finger is innervated by C7. The medial forearm, the medial hand, ring, and little fingers are innervated by C8. T1 innervates the medial arm. At the wrist, both the flexors and extensors are innervated by C6 and C7. At the metacarpal phalangeal joints, both the flexors and extensors are innervated by C7 and C8. In the hand, all the small muscles are innervated by T1. Common palmar digital arteries arise from the superficial palmar arch, which is formed by the ulnar artery. The common palmar digital arteries supply the second, third, and fourth lumbricals of the hand. The proper palmar digital arteries arise from the common palmar digital arteries and supply the adjacent sides of each finger. The palmar metacarpal arteries arise from the deep palmar arch which is formed by the radial artery. Present at the metacarpal heads, they anastomose with the common palmar digital branches of the superficial arch and perforate the interosseous spaces to anastomose with the dorsal metacarpal arteries. The dorsal metacarpal arteries branch at the posterior carpal arch and splits to supply the dorsal side of the fingers. The dislocated fracture in the metacarpals can potentially slit or rupture one of the common palmar arteries supplying to the ring and the little finger, or even exert pressure on the C8 nerve innervating the ring and the little finger.
In regards to Kremai's injury, an X-ray was performed to get a better understanding of the extent of his injury. Looking at the X-ray film, it was evident that there are two radiolucent oblique fractures with displacement on the mid-shaft of the metacarpal of the 4th and 5th digits of the left hand.
Common types of imaging include X-ray, CT, or MRI. Each type is distinguished by the specific technology they use and how well they illustrate what is occurring in certain tissues of the body. In regards to Kremai's injury, an X-ray would have been most appropriate. Had there been only a ligament injury, an MRI scan would have been most appropriate. Imaging with X-rays involves exposing a part of the body to a small dose of ionizing radiation. An X-ray machine beams high-energy waves onto the body. The machine transfers the results of the X-ray onto a film, displaying the parts of the body that absorb the waves. Dense bone absorbs much of the radiation, while soft tissue such as muscle, fat, and organs allow more of the X-ray to pass through them. As a result, on the X-ray film, bones appear white, soft tissue appears in shades of grey, and air appears as black.
So now we're here at the S. Skeleton Family Hospital, and here I have with me my assistant, Dr. Burns. And me and Dr. Burns will be operating on Kremai's hand today. Here we are at the operation theatre as the injured patient requires operator stabilization of the fractured metacarpal. First, we are going to give the patient general anesthesia to relax and allow for the fracture to be manipulated. As seen here, there is the presence of an oblique displaced fracture in the 4th and the 5th metacarpal bones of the hand. Sometimes the fracture ends can be realigned and pinned without a large incision. In this case, however, an incision is needed and direct visualization of the fracture ends is achieved. The fracture will be fixed in place with pins, screws or plates, also called open reduction internal fixation. The fracture will be then immobilized for a period of time to protect the incision and the fracture. We are now done with the surgery. We have placed plates to realign the broken metacarpals. We will place a cast on the hand and the wrist that will restrict movement and facilitate recovery. The overall recovery could take up to months. So Dr. Burns, could you please tell us how metacarpal shaft and neck fractures are caused?
Metacarpal shaft and neck fractures are usually caused by axial loading, direct trauma, or torsional force. As KMI landed on his hand, the pressure on his palm caused his metacarpal to fracture. Metacarpal shaft fractures are extra-articular and can be caused by direct impact from a fall or blow.
So how long do you think the fracture will take to recover?
They heal at a slower rate compared to fractures in the more distal or proximal region as a result of the predominantly cortical bone in that region. The healing rate varies from 3 to 7 weeks.
Oh, poor Kremai. Looks like he can't play the next season. But that was some interesting information indeed.